maybe a lot of you, it's the second meeting because it's the first time, it's the second time, sorry, that the meeting has been jointly between our two research centres, because we've found that there's this commonality in terms of our expertise and experience within sort of this umbrella of health. So it's good to have this conference, and hopefully we'll meet new collaborators, develop new ideas, and further our ref and further outputs. So without further ado then, let's move on to our next speaker, and that is Matthew. So I'll start with
Okay, sure. So good morning, everyone. I'm looking at this room and I probably recognize about 50% of you guys. So for those who don't know me, I am Matthew Lamb, and I am a lecturer in pharmaceutics. I specialize in novel drug delivery technology. So I'm very excited today to be able to share with you a technology that I developed called the liquid pellet technology. This is a platform drug delivery technology. It's been patented and it's heading towards commercial direction. Right. How do you move to the next slide? Oh, okay. See.
You move from here.
Yeah. Okay.
But
What if I press onto that?
because I don't know why it's not opening the slideshow. Let me try again.
Do you want to like an extra minute?
No.
No?
Oh well. For some reason it's not.
It's not showing us.
It was there before. Yeah, it's moving here, but it's not showing there, is it?
It's not.
I don't know if you want to have a try. I don't know why it's not. Let me start this again.
Maybe you need to mirror the.
Good point.
Yeah.
Good point.
I'm going to leave this one just in case it makes a difference. And yours is here.
It's fine.
There it is. I believe it should be there now.
Yes.
Yes. Okay. Thank you. Okay. Let's speed it up a little bit now. So, this is the outline of my presentation. It's to kind of get a better idea of liquid pellet technology. I'm going to begin with talking about the grand challenges of developing future therapies, and then I'll talk about the bioavailability issue, which is a major issue in the pharmaceutical industry. Afterward, I will talk a little bit about how liquid pellet is trying to solve this type of problem. I have some data to share with you, and also I will talk about the advantages of liquid pellet technology, because I guess that's the main point, isn't it? To kind of look at what this new technology can offer. And finally, I'll finish the presentation with the kind of current traction, where liquid pellet is at right now. So let's look at the grand challenges. One of the healthcare technology grand challenges issued by a research council for developing future therapies includes: how do we make a medication more effective? We want to improve this. We want to make it more efficacious. We want to reduce the risk of side effects. And of course, from a company point of view, we want to reduce manufacturing costs, right? I included something extra because I can see this is where we're heading due to climate changes. I think we are heading towards, how we can adopt green technology into the pharmaceutical industry. So liquid pellet touches and have impact on each of these areas, which makes it a very interesting technology. What you see, move on to bioavailability issue. This is a major issue in the pharmaceutical industry right now. Did you know that 60% of the drug on the market and up to 90% in development pipeline are poorly water soluble in your gastrointestinal tract? Basically, that means if you swallow this pill, it's not going to dissolve very well in your stomach, in your small intestine, and so you're not going to If it doesn't dissolve, you're not going to absorb the drug. If you're not absorbing the drug, it's not going to be very effective. So one of the main purpose of liquid pellet technology is to enhance this distribution rate, the way the drug is dissolved, and so it can be absorbed effectively in your body. All right. To appreciate the bioavailability issue, I want to talk a little bit about curcumin. I know some of you may probably know what curcumin is, but I also know a lot of you may not have heard of this word before. So can you just put your hand if you heard of curcumins before? So okay, good. So about 50%. Curcumins, you may about half of you don't know what curcumin is, which is okay, but you probably know what turmeric is. It's the kind of golden spice herb that you would find in curry. And if you go to Starbucks, you can also get turmeric latte, right? I think it's still available in Starbucks. But the reason why you see it in food, like Starbucks, places like Starbucks, is because the media, also influenced by media, but also because turmeric is very interesting. It has lots of health benefit properties. And even in the scientific community, it is considered the golden spice, right? Because it has properties like anti-cancer properties, antiviral, antibacterial, anti-inflammatory. It's very interesting. The only issue is that it doesn't absorb in your body very well. To give you an idea of what I'm talking about, so curcumin is now, is the active ingredient of turmeric. To a safe dose of the high end of a safe dose of curcumin is about 12 grams per day, which is quite a lot anyway. So how much water do you need to dissolve 12 grams of curcumin? So basically, you would need to drink 48 standard-sized bathtubs of water to dissolve 12 grams of curcumin. So that's a big issue, right? Now you can have an idea of the kind of issue we're facing. So liquid pellet technology is tackling these type of challenges. With the technology, we found a way to combine the practicality of a solid pill with the increased bioavailability of a liquid particle in a simple and commercially viable process. And here, I just want to show you how simple it is to make. It's advanced it's very advanced in things you can do with it, but in terms of production, very simple. So if you look at this slide, what you see is you get liquid medication and then you add powder. I'm not going to use technical terms here. So you add liquid medication in the powder. It's kind of like making Play-Doh. You make the Play-Doh and then you extrude it. The Play-Doh goes to extrusion. Extrusion is a fancy word for making spaghetti, right? You're basically making this kind of spaghetti. It's not really spaghetti, it's what actually they found today. I'm just calling it spaghetti. You make spaghetti and then you spherize it. Spherize it, you put it in this container, and below this container you have a plate, friction plate that spins really fast, 4,000 revolutions per minute. And when it spins really fast, it chops these spaghetti to smaller chunks, roll them up into pellets, what we know as a liquid pellet. So you can see that the production is very simple. I've got some data to share with you, and what I want to show you is the kind of results, the performance liquid pellet can give is very impressive. What this is showing you is essentially, there's two slides, so maybe I should stay in the middle. What you've seen is something called a dissolution profile. Down here, you see time. Up here, you see percent drug release. And the drug model we use is naproxen. This is a painkiller, and it's virtually insoluble. It doesn't dissolve at all at an acidic condition. So in your stomach, it doesn't dissolve at all. This test was carried out at an acidic condition to mimic the stomach. This blue line, what you see, is just your conventional naproxen pellet, right? And when you look at this graph, you can see that after 120 minutes, which is about 2 hours, it is 2 hours, you get less than 60% drug release. But when we apply liquid pellet technology, within just 15 minutes, 100% drug release. That's very impressive. That's really fast for a drug that's not supposed to be soluble in the acidic condition, right? So now let's talk about the advantages. What makes this technology appealing? I'm going to look at the advantages from both sides. First, from an R&D, research and development perspective, and then from a manufacturing perspective. So, of course, it makes the drug more effective because the drug is essentially being absorbed better in the body. It's a highly flexible technology. You can have it in a tablet, a capsule-free granule form. You can have multiple active ingredients in a single pill, and you can have multiple dissolution profile in a single dosage form. What does that mean, multiple dissolution profile? I guess you could say it can have fast release and slow release drug at the same time. Let's say anti-diabetic drugs. You want, when after having a meal, you want to immediately control that blood sugar level. So in that pill, it has a fast releasing anti-diabetic drug, but at the same time, it has a slow releasing anti-diabetic drug. So that it controls the blood sugar level very quickly, and then it controls it throughout the day, right? Right, I don't think I have time to talk a little bit, but another advantage is that there's a potential use for pediatric patients and patients who have swallowing difficulty. I used to work in the hospital as a hospital pharmacist, so I've seen firsthand a lot of elderly patients have difficulty in swallowing, to the point that something called a nasogastric tube needs to be inserted into the nasal cavity to the stomach. And how it works is the nurse will have, usually elderly patient takes a lot of medication, 10 plus medication. These medication, most of the time, a lot of them are slow release. Right? These tablets are slow release. So what the nurse has to do to give medication through this nasogastric, they have to crush these tablets and then put it into water and feed it through the nasogastric tube. But these tablets are slow release, they are film coated. This film coating is responsible for that slow release. Right? If you crush these tablets, you destroy the film coating, it's no longer slow release. So what I saw is that patient reach toxic level very quickly because nurse would maybe accidentally don't know, they destroy the film coating and feed it through the nasogastric tube. If you get good nurses who know not to do that, and they can give the drug the bit by bit at a time interval, which is very laborious. So liquid pellet technology, you can have some kind of liquid tablet like this, and you put it into a cup of water, within a few seconds, you get it revert back to its pellet form. And these pellets are individually film coated. There's no crushing involved, just put it in the water and it goes back to its pellet form. These pellets are very tiny. You can administer it through the nasogastric tube, having the sustained release and the film coating intact. That's one of the advantages. It reduces side effects of drugs, and the green boxes you see is how it does that. Because of time, I won't go through how it does that.
About 2 minutes.
2 minutes? 2 minutes, okay. Right, so potentially you can target the liquid pellet in your stomach or small intestine. You can make it float in your stomach. So if you want to target the stomach, that's achievable. And now let's look at the advantages from a manufacturing perspective. It's very cost effective. It's very simple, as you saw. It's much cheaper alternative than soft gel. You've probably seen soft gel as a cod liver oil, which requires lots of heat energy actually to make. You melt this gelatin and you encapsulate the drug. That requires lots of heat energy, which means is not eco-friendly. Liquid pellet, on the other hand, is eco-friendly, uses green technology, sustainable, and it touches things like the UN Sustainable Development Goals. Right. Finally, just to wrap up, have some where's liquid pellet at the moment. It's been featured in Pharma Times magazine. You can find it in InPart. InPart is a very interesting platform that connects academia and industry. And recently, it's been featured in a Caliva Pharma webpage. You can see it's read a small article about it. Exciting development for future of all dose drug delivery. And that's it. Okay, thank you. So I guess 5 minutes.
Any questions?
Yes. Sure. Thank you.
Just a quick question. You mentioned pH 1.2.
Yes.
Is this required for the release of active ingredients?
No. The pH 1.2 is to mimic the stomach, because your stomach is about 1.2 to 2, depending if you eat food or not. So it's kind of like mimicking the stomach condition, so you know how much the drug would release in the stomach. Yeah.
So if it is taken after consuming food,
yes.
Imagine if the pH is not like higher than this. Some people drink water, for instance,
yes.
while they are eating. How is this going to work in terms of absorption of
Okay, if the pH increases, the absorption is going to be better.
So it's
Because-
not limited to that.
Yeah, no, because
acidic.
it depends on the drug. So the drug model you saw was naproxen, is a weakly acidic drug. A general rule is that a weakly acidic drug is more soluble in alkaline condition. So if you increase the pH, it's actually better. You get better absorption. Yeah. Okay.
Any more questions? Actually, I've got a question for you. So I've worked for a long time with vitamin A in the past, where we've given vitamin A supplements to participants.
Right.
And we always tell them to take your capsule with some fat in the meal. So with your approach, then you wouldn't need any level of fat in the meal. You just take the capsule by itself and nothing else.
In terms, it depends on what type of vitamins, because what I'm working on is drugs that is not soluble in aqueous environment, but if it's also not very soluble, not permeable in the cell, then maybe it's a good idea. So it depends on the property of that active ingredient. Yeah, it depends. Thank you.
So it's bit time. I wanted to, you mentioned some conditions. I mean, if I understood you, you mentioned children for pediatrics and medication, and you mentioned patients with difficulties in swallowing, which include all cancer patients, and presumably people with respiratory diseases or
Yeah, a lot of elderly patients as well, the palliative care, or the very old, yeah.
And hasn't been any sort of testing on this already?
It's still in an initial phase.
This is very initial.
Yeah, it's still in the initial phase. There has been tests, and I had in the past worked with Pfizer. They gave me this unknown compound, and then they want to know its performance, but in vitro test.
Okay.
In vitro test. So we have done it, and we got very good data from that. So, but in terms of if you're thinking about testing the human clinical trial, that's going to take millions of pounds. So I would probably have to find
A good sponsor.
a business, funding source.
That's fantastic. Thank you very much.
Thanks, Matthew. Right, next speaker is Cleona. Hello, Cleona. Yes, your magic touch with
What to
the.
do is it off? Yeah. Okay. So this is. No, let me see if I can. I have a laptop, but I don't know if they have. Ideally, I've got your slides, but I don't know why this.
Just press escape.
No, well, it seems to have crashed. So probably you can bring your laptop. Is it crash, isn't it?
I see the cursor.
It's because we don't have. Oh, no. If you let me, what do I do? No, task manager. This one. It's not the mouse is not responding. Here we are. Now we're back.
Better with technology
Liquid Elmulan. I can't remember your presentation. Can you recommend? Yeah, this one. This one. That's it. Now I just need to ensure that it comes up on the screen. Yeah.
Right, so 15 minutes out, sort of give you a nod when you've got 2 minutes left.
That'd be good, thank you. So about yeah, okay. Is that? Yeah. So hi everyone, I'm Cleena. I'm a PhD student and I've Dee as my supervisor, my first supervisor. And I'm just kind of at the stage of waiting for my Viva, so handing in my PhD. And so what I'm presenting today is a bit about kind of the final chapter, the final piece of research that was conducted as part of this. Just for an overview, I suppose the overall PhD was looking at national guidance for eating disorders. I clinically work as a dietitian in eating disorders, so that's kind of why. So I'll go ahead. This chapter was looking at clinicians' perspectives on the assessment and treatment of typical and atypical anorexia nervosa, and it was a reflexive thematic analysis of their experiences and perspectives. So I'm aware that obviously lots of people won't work in eating disorders or have a huge kind of knowledge necessarily of eating disorders in the UK, but for some background, our national guidance that spans kind of the UK has been recently updated in 2022. So kind of how we're advised as clinicians to manage eating disorders in kind of all settings. The national guidance we have has a big update, and the name of it is the MEAD, which is Managing Emergencies in Eating Disorders. And what it does is provide kind of guidance on how to kind of assess and manage risks that arise in eating disorders across the age range. And that could be risks that arise in the community or in inpatient settings, or kind of outside of that as well. So the main thing that the MEAD kind of hopes to do, the guidance, is to help us kind of be aware of when someone may need a kind of medical admission. So when they may be at very high risk, and how we kind of can recognise that earlier and make sure that it's managed appropriately. And if they need an admission, then they're admitted and again looked after in the correct way to keep them safe. And the kind of scope of the guidance is for clinicians that span all different kind of specialities. I suppose for kind of context, young people and adults with eating disorders may kind of be admitted to general wards. They may be seen in general clinics. They're not only seen in kind of mental health services. So therefore the guidance is kind of for everyone that may encounter these patients. And although I suppose it's been updated in 2022, but it has been around since 2012. And even though it's been around for kind of more than 10 years, there's not really been any research or evaluation necessarily kind of specifically looking at that and how people use it or how they kind of feel about it, if they feel it's useful. So therefore that was kind of the nature of this overall project, was looking at this guidance. Again, oh, I thought someone said something. For context, just I suppose the guidance and what, eating disorders encompasses a broad range of different diagnoses and difficulties, but specifically, we were looking at anorexia nervosa. The reason for that is the guidance prior to 2022 was focused only on anorexia nervosa, and therefore kind of at the beginning of the overall project, that's what we had focused on. And for context, anorexia nervosa, kind of traditionally, degree of underweight, so how underweight a person was kind of seen as a marker of how unwell they were, and a marker of kind of medically how unwell they may become or how high risk they may be. In kind of recent years, there's been a recognition of something called atypical anorexia nervosa, which is a term that's kind of not necessarily used all the time, but clinically we would use it. But all it means is that someone may have all the criteria for an eating disorder. So they may be restricting their energy intake. They may have lost a lot of weight. They may have an intense fear of gaining weight and have all the kind of cognitions that would align with anorexia nervosa, but they haven't become underweight. So they're not under a certain weight threshold. And as you can imagine, there's kind of an obesity epidemic, etc. So people that may already have been of a higher weight but have lost lots of weight may take a very long time to reach that threshold. And that doesn't mean they don't have anorexia nervosa, it just means they may lack that one criteria. So for that reason, that group have been captured within this research as well. The overall aim of this part, so this study, was to gather the perspectives and experiences of the clinicians that are looking after these young people with anorexia or atypical anorexia, and kind of understand how they have perceived the MEAD guidance, if they've perceived it to be helpful, how they've implemented it into clinical practice, if they feel it's helpful in knowing when to admit someone to hospital, how to kind of manage the risks that they encounter. And the core kind of objectives were to define the role of the MEAD guidance in the decisions around medical admissions for the patient group that we were looking at. I suppose, again, for context, although the mood guidance is kind of mainly for thinking about emergencies and medical admissions and management of that, it does also span, again, quite a large scope of thinking about transfer between units, kind of the different risks or difficulties that come up during treatment. So we were kind of trying to focus just on that main admission kind of element of it. In terms of the methodology, so it was a qualitative piece of research, and it was kind of the first time I was doing qualitative research. The rest of the PhD in research was quantitative. And it was kind of very collaborative with different disciplines. So what I mean is that kind of regardless of if someone was a doctor or a psychiatrist or a nurse or a psychologist, whatever their profession was, the idea was to try and collaborate across the different disciplines and also across the different kind of settings. So again, not everyone will work in healthcare here, but there's not a split as such between mental and physical health, but there is quite a big difference between the two services. And often when there's overlap, things about patients can get missed. There can be big gaps in treatment. And so when we think of something like an eating disorder and specifically anorexia, as you can imagine, it may be that we're kind of managing all mental health risks in a really kind of thorough way. But equally, if we're only thinking about mental health, we may be missing a large part of what the condition, kind of the difficulties it causes with physical health. Because as you can imagine, if someone's not eating or they're kind of engaging in behaviours that lower their weight, then they're going to be at quite high physical risk of malnutrition and all of the consequences around that. So a big part of this was trying to kind of pull together professions from all different disciplines and settings and gather their perspectives of how it's been trying to work with kind of the other side or work together using this guidance. The reason that we kind of added some qualitative research to the overall project was to try and deepen our understanding of the topic. So the quantitative data gave lots of information that was really helpful, but I suppose what it was missing was a kind of very deep understanding of the kind of topics and themes that arise around the guidance that we were looking at. And we thought this would enhance the findings of the overall project. We also used individual interviews rather than focus groups. There was kind of two reasons for that. One, very practical of, we did offer focus groups initially, but actually due to clinician time and being able to schedule them, there was quite kind of poor uptake. In addition to that, with focus groups, I suppose there's a chance that people may not be able to speak fully freely. And especially the nature of this project where there can be some kind of contention between the two sides of either mental health aren't doing enough or physical health aren't doing enough, which is not the reality, but I think that can be the feeling sometimes with these patients that are really complex. So again, we used individual interviews so people could speak freely, say kind of what they wanted, give anonymous feedback and anonymous kind of responses to us in the interviews. We looked at sample size calculation, and again, there's kind of two schools of thought that we encountered where there's kind of data saturation and thinking about that for sample size calculation, but equally kind of Braun and Clark was kind of the other school of thought that is, I think, more widely used. So we did look at both, and by using Braun and Clark and both looking at data saturation, that's how we kind of developed our sample size, which was relatively small, so it definitely could be bigger, but that's kind of how we looked at that. In terms of data collection and the analysis, so we advertised on kind of public domains, and again, what that means is that we have in Britain, we have the British Eating Disorder Society, which is a public platform that anyone working within eating disorders, or that's a clinician, even with a special interest, can join the platform, and it's kind of very widely used across Britain, and research is shared there, conferences are shared there, job opportunities, there's multiple different things that are shared on that platform, but equally it's a good place to advertise for studies across kind of where different disciplines may see it. The use of kind of semi-structured interviews meant that we were able to ask direct questions that focused the interviews, but equally there was kind of dialogue between that where people were able to discuss different elements and give their responses. The people that did take part in this, so we did manage to have psychiatrists, we managed to have nurse kind of nursing representation, psychologists, dietitians, and kind of doctors, which might mean junior doctors or non-specialist doctors, and also then paediatricians that were kind of working within the NHS. Again, the reason for having NHS and not necessarily private practice included isn't because it's not relevant to private practice, but there's a lot more heterogeneity in how risk is managed and how protocols are followed in private practice, whereas the NHS are quite strict and quite kind of focused on how risk is managed, and everywhere does use the Mead guidance, whereas that might be different if we go out of that setting. And then we use kind of electronic transcription and then analysis of the data, and kind of the reflexive thematic analysis conducted, which means we kind of engaged with the data and generated themes and sub-themes from that. This is just an image of what kind of anyone that was interested in the study who looked on the platform where we advertised would have seen as an invite for them to take part. Overall, just trying to talk through the general results. I suppose, first of all, as you can see, the sample size isn't huge, but again, for a qualitative piece of research, that again, we could roll out and do a much, much wider study. But as a first kind of look at this, this is who we kind of recruited. So again, I won't talk through again who we had, but they were the different disciplines and how many of them. In terms of the themes that were generated, and I think this is kind of the key part, obviously, of the presentation or of the kind of project, where the key themes that came up were around a common language and that ability of the guidance to give people that work in mental health, who may be talking very much around kind of psychological distress or issues or kind of risks that may be more to do with suicidality, self-harm, or kind of, as I said, like the level of distress being unmanageable in a community setting, that type of dialogue where that's how we speak about risk. But a common language that can be shared with a physical health kind of setting where we're thinking more about numbers, what's someone's blood pressure, what's someone's weight, how much weight have they lost. I guess the guidance, what it did and what clinicians were able to say was that the guidance helps kind of focus on what are the risks and how do we communicate those to a setting where they talk about risks differently. And that was kind of one of the themes that came up for all clinicians. It also kind of facilitated collaboration. So it kind of, the guidance, what was helpful about it was that it kind of gave a focused direction of how you work together as different services and how different disciplines fit into that, and how people collaborate and how important that is. For again, when you have someone with a complex illness like an eating disorder where they have physical and mental health needs, how you then coordinate that between the different services that don't maybe that commonly work together or have the pathways unless you develop them. So they thought that was very helpful, and that was one of the key points about the guidance. Another kind of part that came up, which relates back to what I'd mentioned about kind of anorexia affecting people of a higher weight, but also of kind of an underweight status, is that kind of looking beneath the surface. So that kind of idea of when someone arrives on a medical ward and they have an eating disorder, if the risks aren't obvious, so for instance, if they don't look physically very unwell, very underweight, it can be hard to recognise what are the risks and what are we being asked to do. 2 minutes. Okay, I'm nearly there. But essentially they kind of said the guidance was helpful, but equally could be enhanced or improved by having more kind of information about what risks are we managing if we're not managing low weight, risk of malnutrition, or if we are managing that and it's someone that's not underweight, how is it different, and how do we make sure we're managing risks appropriately in a physical health setting if they're coming from mental health. The last kind of theme, bear in mind time, I won't spend too much time on, but kind of refeeding syndrome, again, for those of you that don't know what that is, just means that when we start to provide nutrition again to someone that's very malnourished and hasn't eaten in a certain amount of time or has lost a lot of weight, there's risks that can occur from that. And therefore, sometimes, we would always feed slowly and integrate nutrition slowly in a very safe way as per the kind of protocols that are available. And what was said basically was that the guidance talks a lot about this, but actually in young people it's not that common. There's a certain level of protection that young people appear to have with eating disorders. There's also the risk of underfeeding someone, and that was kind of expressed as something that should be more prominent in the guidance, to kind of highlight that there is risks on both sides, and if we're too cautious, we're at risk of making someone more potentially unwell, or higher risk if they lose more weight from underfeeding. I won't go through the clinician quotes because I know that there's only a small amount of time left, but it just kind of emphasises what those themes had highlighted. But overall, for the conclusion, basically we found that as a first look at kind of how clinicians are using this guidance, that it was used widely. It did kind of support the decisions that are made around medical admissions, around eating disorders. So kind of the nature of the guidance, the kind of reason it's there did seem to kind of fit with what clinicians were saying. And that it was helpful for communication, joint working between services, collaboration, multi-agency working. And even though all of those things were really positive, there's still room for kind of maybe further improvement, further research on how we can stratify risks and kind of be more focused on what exactly we're managing, who is at risk of what exact risk, that should be kind of more prominent and maybe more directly focused on in the guidance. And I think my time's up. And any questions? Thank you.
Any questions?
It was a really interesting presentation, and I just wondered, like, in people living with obesity, there's a very well recognised risk of disordered eating, and as you've spotted, also atypical anorexia nervosa. But I just wondered, did you come across any evidence of stigma in relation to people who are living with overweight or obesity among the people that you spoke to? Because again, stigma among medical health professionals, healthcare professionals, is very well recognised in relation to overweight and obesity.
Yeah, definitely there was. I think, and again, I suppose possibly in a direct and in an indirect nature. And I think the stigma, again, if you're thinking of a paediatric ward, and I think some of the paediatricians who would be maybe the gatekeepers of that ward, I think there is kind of the narrative of, well, if someone's not underweight, they're not unwell, why are they coming to the ward? The guidance is really useful for being kind of saying that they're not at risk, which I think that was interpreted wrongly in some ways by some clinicians. But there was that kind of still narrative of, if someone's looking okay, overweight or kind of a healthy weight, then they're not unwell. And I guess that's, I think in eating disorders, I think that's a stigma that comes up a lot and stops people from seeking treatment. I guess on the other side, there was less maybe discussion around being overweight or that kind of dialogue, but it was more about, if you don't look underweight and don't look unwell, then sometimes you're perceived not to be unwell, whereas actually we know that anorexia affects lots of different people. You don't know by how someone looks. I don't know if that fully answers your question, but that was...
But it sounds like the sort of education and training needs.
Yeah, and I think slowly it's getting better, but there's definitely, different professionals, and depending on... Yeah.
Thank you.
So,
It's a really interesting study and a really nice way of looking at clinical guidelines and the implementation of them, because we always kind of look at it from a quantitative audit perspective. What's the outcome when people follow the guidelines and the data? So it's good to get the views from the people who are actually doing it. In terms of my question, I just wondered, forgive me, it's quite, how did you approach the reflexive nature of the methodology and kind of dealing with your own potential biases when you're analysing the data?
I think that's a good point. I think being aware of the biases that I would have as a dietitian working in eating disorders, and I suppose in addition to that, I suppose engaging with the data and developing kind of the themes is a long process, and I guess going through each transcript, but equally I suppose having someone else look over it and make sure that even though I have my own biases that we're kind of looking at it. But I think again, with qualitative research, I can't not be a dietitian working in eating disorders, so I think it's stating that it's from my point of view as well, that I've looked at this data, we've looked at this data, and therefore there may be biases that we're unable to avoid. That's kind of how we approached it.
other questions? Can I ask you a question?
Yes.
My question, because I'm not a dietitian, but is atypical anorexia, is that sort of like a prelude to full-blown anorexia?
No, so it's, again, a bit of a contentious term. There's not, and I think patients don't perceive it well, and I don't think it's potentially the correct term. But again, it is difficult. The risks are different if it's not one is more severe necessarily than the other, but they are different if someone's of a very, very low weight versus if they're not of a low weight. They're different, and that's why there's a differentiation. Yeah. So it's not a preclude. You can have atypical anorexia nervosa. Usually we would just call that anorexia and not necessarily differentiate unless it's helpful for the patient. But it just means that you meet all criteria, and it's in kind of the DSM, so the diagnostic manual, but it's as a kind of example of a category under there's other diagnoses like eating disorder not specified or other specified eating disorder where people may meet a lot of the criteria but are missing one. Okay. And so they might fit in that group. So to kind of differentiate them further from that really heterogeneous group, we have atypical anorexia nervosa. Yeah. So it can be a standalone. So it's not preclude. People don't necessarily. Yeah.
Good. Great. Thank you very much.
Thank you. Thank you very much. Thanks.
So our next speaker is Hilda. So she's our newest member of staff.
Let me try to admit that this is going to work. I'm going to set the timer on my phone so I can see how I'm doing time-wise. I'll just so I know where I am. I know that would be helpful. Hilda, remind me of your presentation. I had it here. I can't actually see. They're so small, to be honest. It looks like it might be actually it's a community food, that's it. So to move the slides, is it just the downer? Yes. It should work. This is where it should work because it's there. Okay. Thank you very much. No problem. Okay. Yeah. Okay. And I'm just going to set my timer. Okay, thank you very much for your interest in my work. As John said, I'm a new member of staff. I only started in January, so I'm just going to talk you through some of my areas of current research interest. And they're primarily around community food-based research. All of the images are from particular research projects that I've carried out with colleagues. So my interest in this started back kind of, I suppose, throughout the process of Brexit and the long debates about whether there was going to be a deal or no deal, and I started thinking about food and the implications politically in relation to that, and had a very serendipitous meeting with a colleague in politics at Kingston University, which is where we both worked at that point, and we set up what's turned out to be a fantastic, enduring research collaboration. So we wrote a paper together looking at what the pandemic taught us about the potential impacts of Brexit in relation to food security. And we then went on to look at how the pandemic had impacted upon food provision, particularly at the community level, in two locations. So I collected data in the borough of Kingston, and Ronald, my collaborator, collected data in Sussex, which is where he lives. And we just used a snowballing technique. We phoned people, we emailed people, and then in every interview, we asked them, do you know somebody else we should be talking to? Who are the groups we should be talking to? Who are the key people? And so from that, we built up a kind of a network. And we were basically asking them what happened with relation to your food provision in the pandemic. And we found that there was an awful lot of really good practice that occurred. A lot of amazing innovations occurred in response to the pandemic. And although there was a huge increase in need for food support because of the pandemic, at the same time, there was a huge influx of time and talent and money and resources. So while we were collecting that data, we also grew our research team. Dee at the back is part of our research team. So, and we also invited Navena Nanchiva, who was also then at Kingston University working in politics. None of us are still at Kingston. So we're a research team of 4. So we wrote up the data on the innovations in response to the pandemic, and we wrote a little blog about it as well. But during the course of that data collection, we came across 2 community projects that particularly interested us. And one was based in Sussex. It's part of the Sussex Community Development Association, that's SCDA, which is like a food network across the borough of Sussex. And Steph Lake is the person in charge of that network. And Steph had moved away from food banks towards a community supermarket model. Now, if you're not familiar with those, the food bank, you typically have to be referred into it, so you have to prove your level of poverty. You're only allowed to access the food bank for a short period of time, despite what you hear in the media. People can't just roll up and demand a food parcel.
And you're given a food parcel which is typically long life foods. There's very little fresh fruit or vegetable, and there's very little choice about what's in the parcel. So it meets an emergency need, but it's not meant to be any sort of a long-term solution. And Steph had observed that this was not, in her view, the best way to be delivering food support, so she had turned 2 of the previous food banks into community supermarkets. So they're much more akin to a shopping experience, but if you could imagine this room suddenly becoming a little supermarket, it's like a pop-up supermarket, typically using surplus food, often using a pay-as-you-feel model, so people can donate money if they want to, but they're not required to pay if they're too hard up. If they can't afford it that week, that's fine. And often it will contain at least some limited fresh fruit and vegetables. So you've got the element of payment, if you can afford it, and also the element of choice, both of which are really important contributors to dignity in the experience of shopping. We all have choice. Why would you not have choice? So we were very interested in that. So we've carried out 2 evaluations of the community supermarkets, so in 2 locations at 2 different time points, and we've collected data using questionnaires and also interviews. So we've qualitative and quantitative data. And we wrote 2 impact reports for the organisation, so that they could get direct feedback from their users and understand what were the things that were working well and what were the things that were not working so well. And they've also used that data to apply for funding to keep themselves going. We found it a really positive innovation that had led to an increase in dignity and an increase in choice and potentially an improvement in terms of dietary diversity. So again, we wrote that data up, Steph being one of our co-authors on that paper, which was lovely. And we just heard about a week ago, I think, that the bottom paper has been accepted. So we're really pleased about that. And the second project that really interested us is one called Brightbox. So you'll see from the spelling of Brightbox that although it sounds like it's light and shiny, it is actually an acronym, and it stands for Building Resilience in Today's Environment. And it's a new innovation that started in Kingston, in the borough of Kingston, actually from a charity that was not a food charity before the pandemic. It literally switched to food overnight when its core business was halted. And Brightbox is a recipe box scheme. So you can see a row of boxes there. I don't know if you can see them clearly. That's usually what I'm doing on a Friday morning, is helping with Brightbox. So I do the research, but I also am very hands-on with the project. And we typically pack about 200 boxes on a Friday morning. It was 300, but we now have a new hub, so some of that work has gone elsewhere. The boxes are packed with pre-weighed ingredients to make a recipe. The recipe is designed to be nutritious, to be made by a child. So the idea is that children are doing the cooking. The box is given to the child at school. It's beautifully wrapped. They never know what the recipe is going to be before they open the box. So there's a lot of excitement about what's in the box. And so we as volunteers are making all the, weighing out all the ingredients, filling up the boxes, packing them, getting them down to the vans so that they're arriving at the schools. And we carried out an evaluation of Brightbox. Now, we again have done 2 different evaluations of Brightbox at 2 distinct time points. I should say that Brightbox is now in 7 different London boroughs, and they've just got funding for another borough, and it's also in 1 location in Northern Ireland. So it's really growing as a community project. We found that there were a huge number of positive behaviours associated with Brightbox. Not just that, the excitement of the box, but children getting more involved in cooking, more involved in eating together as a family, talking about food more. So potential there to improve their diets. Dee and colleagues at London Met also carried out a nutritional analysis of all of the recipes. Dee and I are working on a paper to write that up at the moment, but again found it to be very, very positive. So we wrote impact reports, which we gave back to the organisation. I should say that all of this work with community groups, we co-develop all of the tools that we use for the research. We don't decide what the questions are, we ask them what it is they want to know, and we work together. And the image, this beautiful image of this little girl, that's one of their photographs that they put on the cover of one of our impact reports. So we observed a couple of really interesting things in collecting the data. One was a potential for a particular benefit for children with special educational needs, especially those children with very restrictive intakes. We heard from parents and carers that those children, because of their involvement with the food and the feeling that Bright Box was for them, were actually more accepting of a greater range of foods. So we've got a small little pot of funding, and we're carrying out a study at the moment, a small little study, looking specifically at special educational needs children. And we also got another small little pot of money, and we're using that to explore Bright Box more longitudinally, and also to see if different delivery of Bright Box in different schools affects the impact. So those are ongoing studies. We were approached by the Real Junk Food Project in Richmond. You may have heard of it. It's the Real Junk Food Project is a kind of a national project, but it was implemented locally in Richmond at 3 different locations. And the person who's in charge of the Real Junk Food Project heard us present Bright Box at one of their meetings, and so she came to me and asked, would we evaluate the Real Junk Food Project? So they use surplus food that would otherwise be binned. They, at their 3 sites, they have different methods of delivery. So in some, they're just giving the food away to people. So it's like a food hub where people just come and take what they need. And at others, volunteers are cooking and preparing fresh meals that are then given away at the cafe, using, again, surplus food. So we carried out an evaluation at all 3 sites, again, using questionnaires and interviews, and we wrote an impact report on that. I presented some of the data on the move away from food banks to social supermarkets at a conference in France in December. And most recently, Navenna and myself have done a very small little evaluation at a really tiny little grassroots community cafe called Kitchen Roots in Surbiton. And it's very sadly just closed down because it got flooded. All of these locations are so precarious. They have no funding. They're doing everything on goodwill. So we found really positive benefits from both of these surplus food projects in relation to not just the food that they offered people, but also the sense of community that was offered, the acceptance of people who were often on their uppers, and the feeling of being welcome somewhere and being in a space that was safe. So we're very much hoping that the work we've done with Kitchen Roots will enable them to get funding and a new location. Throughout, I've been really interested in the views of volunteers, partly, I suppose, because I volunteer, but also because I just think it's a really interesting position to be in. So I've carried out more than 51 interviews with volunteers across different projects, but 51 from volunteers in Bright Box and the Real Junk Food Project. And that data we've presented, Ronald and myself have presented at the Food and Work Network, which we're both members of. And we've written a blog about it, and we've also just literally heard a couple of days ago that our paper on that has been accepted for publication. So we've identified some of the ethical issues and dilemmas that volunteers working in this community food provision face. And most recently, we've moved into growing projects, so community food growing projects. We're interested in those from an environmental perspective, from a nutrition perspective, but also from a community perspective. We're collecting data at the moment from a range of different community projects with the intention to feed into the development of a growing strategy for Kingston Borough. So the local authority know what we're doing, they're working with us on this. So I finished doing some work at a small farm in New Malden, which is a farm that's growing Asian vegetables in UK conditions. So as you can imagine, that's quite a challenge. And so I've just given them the impact report. We have an ongoing project at Kingston University among staff and students to explore benefits and barriers to being involved in growing. We've been in discussion with Roehampton University about evaluating their project. It's called Growhampton. And there's also work I'm doing with a number of small community garden projects. Through our research, we've also funded several meetings of the Kingston Good Food Network, which is a borough-wide network of community food groups. So we host the meetings at the university, we feed people, we allow them to have a safe space to explore issues together. And so the next 2 meetings that we're planning at the moment are going to be about growing, and we'll use the data from those meetings to inform the strategy.
And the final one in this particular group of projects is my latest baby, and this is called Kingsgate Student Pantry, and it's basically a community supermarket that we've set up for university students, and it's a kind of a collaboration between the community and the university. Not the kind of high-level university, but a few staff and some students. There's no high-level interest in this at all. So I wrote a paper back in August 2022 to the senior leadership team, presenting the idea, the need to address food insecurity among students, and proposing that we set up a community cafe or a community supermarket, and it died a little bit of a death. But I went on to collect some data from students. I asked them about their concerns about food and the cost of living crisis, and I got 1,090 responses, which I've never ever had a response of that number from students before. So in various little presentations and publications, I've been proposing the idea of community-university collaboration so that we work together, each giving to the other. And we have been working with our community groups. We've been giving of our expertise. That's cost them absolutely nothing. We haven't asked them for anything, and indeed we haven't asked them for the student pantry either. But when at one of the Good Food Group meetings I mentioned this 1,090 students, there was an immediate response from the community groups, and they have taken the bit between their teeth and they've set up a pantry. So that's how I spend my Sunday afternoons now. I've been volunteering at it since it started in October. We now have over 150 students registered. We typically serve 70 in a given Sunday. We're open for 2 hours. And these are some of the images from the pantry. So it's a social space. We provide free coffee and tea and cakes so students can mix with each other, but also with community volunteers. We have the supermarket itself. They pay £5 and they get between £20 and £25 worth of goods. We have signposting to community and university support if they need it. And we also have cooking demonstrations, usually once or twice a month, using Brightbox recipes. Finally, my other research interests, which are a little bit not community food related, I have had a long-standing interest in obesity, hence my question to Lena. But I'm a member of 2 committees on obesity, one a UK one and a European one. And in the European one, we produced 2 papers suggesting medical nutrition guidelines for obesity, one in adults and one in adolescents and children. And since we produced those papers with colleagues in Greece, I've been working with dietitians to explore their awareness of these guidelines, the extent to which they're already being implemented, what are the barriers to implement them, and what would help. So we're writing that up at the moment. And the last thing is just I have an interest in different aspects of teaching and learning. So I've done research work in all of the areas that you can see there. And Preet and myself have just had ethics approval for our first pedagogy project here at London Met. And that's in a nutshell what I'm up to. So thank you very much for your interest. These are the members of our community food research team. So that's Ronald, you know Dee already. You know me, this is Sarah, who's one of our final year students, who's doing some absolutely sterling work, and this is Nevena. Very happy to answer any questions you might have.
Any questions? Yes.
Is the community food group mainly for London Met students, or is it for students from other universities?
Do you mean the pantry? The community? Yeah. No, yeah. It's down in Kingston. It's physically based in Kingston, so it's typically for Kingston University students. Although if other students, like from St Mary's or other local universities, come along, that's absolutely fine. We wouldn't turn anybody away on that basis. We have had students from some other universities show up.
So
it's really impressive work. It's incredible. The student pantry is something to your credit. It was something that we tried to develop here. There were so many challenges which I'm sure that you managed to overcome. I think where we struggled was linking the community into this and getting that community support and the base. And I think part of the challenge was the level of deprivation in this this area, that there were lots and lots of other schemes going on, and it was just hard to find a place for London Met. But would you see a kind of approach for the same thing here?
I mean, I should say I haven't set up the community pantry. Like it was an idea that I floated, that I really wanted, but I don't have the expertise or the knowledge or the networks to do that, or indeed the time. So it wouldn't have happened without the community. The community groups have led on this, so it's really their, it's kind of a mutual baby, but they're probably more parent to it than I am. But I think you have to have a strong community leader who takes ownership and who knows the networks and who knows who to contact. And I think the other thing that's been incredibly helpful with it is Sarah, who's the student. She has really taken ownership of it, and she's developing lots of relationships with different companies to get them to donate products. So there's so many logistical things to think about. Like I volunteer on a Sunday at the actual pantry, but there's a couple of other days in the week where there's deliveries coming in, and so you need volunteers for all of those. You need volunteers to sort things out and store things properly and all of that. And Sarah's been really instrumental in that. And I think it is really that partnership between the community and the university. We had established relationships kind of over several years of doing research with them, and we'd never asked for anything. We didn't ask for this either, it was them kind of thinking we have to do something about this when they heard of the level of need. I think sometimes there's a perception that students don't really have need, that they must be very wealthy because they're all paying £9,000 a year, and actually that's not the case at all. And we all know that. So I don't know. I mean, I don't know to what extent there are pre-existing relationships that are there, or what the networks are that the university is part of. But if there are kind of key players, then yes, there's no reason why it couldn't happen. But it is an enormous amount of work, as you know.
And that's reassuring.
Awesome.
I'm just wondering if, I'm really impressed. Is there any partnerships with health? I was just thinking about, my own perspective working in eating disorders. We do have lots of families in quite, dire circumstances when feeding their child is obviously extremely difficult, especially in the context of having mental health illness. I was just thinking, would there be any funding opportunities from a collaboration between NHS or services, or not really?
I don't know, to be honest, to what extent the NHS funding would fund a community initiative. I mean, there are definitely community funding pots that universities can't typically go for, that community groups have to lead on, and whether or not they cover these specific things is also slightly awkward. We do, I mean, we are part, like public health is part of our Good Food Network, so we're very much in conversations with public health and healthcare professionals, but this is very much a community rather than, it would be seen as very different from the NHS, I think.
That's just really interesting, like sense of my family's perspective, if there are things like that in their area, it's useful for them.
I know, I think that's for my own children. I'd love if there was a community supermarket nearby, but sadly they don't live near enough to Kingston to go every Sunday. So yeah, I think the funding thing is always problematic then.
More research.
Yeah, absolutely.
Okay, thank you very much. So now we have a refreshment break, so we'll come back for 11:30. Team copies available?
Yep.
In plastic cups.
To put this to look, I lost my. Why? I mean, it's like the pad. I don't see the sort of the mouse here.
Yeah. Everything seems very small. I don't know whether you like it that way or not. I can see the cursor.
I don't see. There it comes back. So
we're on schedule. 2 minutes.
Oh, wow.
We have these three, so we have friends for.
I didn't know that. That makes sense. But it should be coming. Yeah, if I stood here, surely it will. Yes, I'll pass it.
Okay.
Oh, sorry, you can talk here.
Bit cold in here. Please to introduce, I don't know where to stand giving the principal lecturer in psychology, Olaide Phillips, and she will be delivering a session, yes, for around 15 minutes. You want to introduce your.
I will do, thank you. Hi everyone, so I'm Olaide Phillips. I'm principal lecturer in psychology in the School of Social Sciences and Professions. Alongside my role, I'm also a PhD student, and I'm studying or investigating racial trauma and the effects of that on the student journey, but specifically looking at academic engagement, well-being, self-efficacy, and academic success. Actually, racial trauma is really understudied, and looking at racial trauma with the student journey is virtually it's not studied in the UK at all. So this is pioneering in that sense. Throughout this presentation, we're looking at racial trauma, so of course, a bit of a trigger warning as we go through this. Eight minutes, 46 seconds. Do you know what happened in 8 minutes and 46 seconds? Anybody? Absolutely. So it took 8 minutes and 46 seconds for Derek Chauvin to remove his knee from George Floyd's neck. We all saw the protest. It was all over our TV screens, our social media through the first lockdown. Ended with loads of protests that we were all very much aware of because it was everywhere, right? The reason I bring this up is because racial trauma does not have to be a first-hand experience. It can be vicarious, comes about through watching or hearing other people's experiences. We are constantly exposed to these things on TV, social media, hearing other people's stories. Racial trauma is cumulative. That stress doesn't have to become traumatic until, though, it reaches that threshold, that last straw after a series of exposures, which actually we are constantly exposed to, right? Let's look at racial trauma in a little bit more detail. So, last night I actually received a book by Yamonte Cooper. It's titled Black Men and Racial Trauma. In the chapter looking at racial trauma, Yamonte expresses that racial trauma is really understudied and ill-defined. And actually, I'll take that a little bit further, because all of the definitions, all of the models, the theories are based on the African-American experience. But actually, that's really limiting, because we can't take that into the UK context or any other communities, actually, right? So actually, there's a lot to explore in that regard. One definition of racial trauma is the psychological response to cumulative racism and race-based stress. It includes things like overt racism, discrimination, oppression, racialized microaggressions, and internalized oppression. Loads of other things. Racial trauma, again, can be direct or vicarious, just like that 8 minutes and 46 seconds. it has a significant association with the psychological and physical symptoms that some people may have. People may develop post-traumatic symptoms as a result of racism or racist experiences. Some of these are listed on the screen, and it's really problematic, though, to link this to post-traumatic stress, just because these are perpetual and not time-limited, right? So with that said, what happens when a student walks into university for the first time with racial trauma? This hasn't been looked at, but actually some research has looked at race at university. So let's have a look at that quickly. So again, a lot of this research has happened in the States. We need to consider this in the UK context. So academic engagement, there is no current literature linking academic engagement to racial trauma. However, non-traditional students, which includes racialized students, as well as first-generation low-income household students, receive a hostile campus environment, and this affects their sense of belonging. Sense of belonging, we know, strongly correlates to retention, engagement, confidence, mental health, all the things that we know a student must have to be successful, right? 16% of Black students in 2012 experienced racism at university. What is that experience? How is that affecting their journey? What about well-being? Jason Ade looked at this quite a lot. You may know Jason Ade. He was around speaking to us during the development of the ESJF, and actually he was in the media recently, Black professor in Cambridge after speech development, autism as a child. He looked at racism, structural discrimination, cultural incompetence and insensitivity, and actually how that's linked to the onset of Black students' mental health. In the States, perceived racism in academic settings was associated with high blood pressure in African American college students. Really interestingly, this was both when they were awake and asleep, okay? So psychological and physical here. Self-efficacy, so one's belief that they can perform. The research here is very limited when it links to racial trauma, especially, of course, in the UK. Here again in the States, research has indicated that ethnic minorities have lower senses of self-efficacy, or sorry, rather just self-efficacy, in comparison to their white counterparts. Really interestingly, in predominantly white colleges, Black students have lower self-efficacy than Black students in historically Black colleges. Why is that, right? Finally, academic success. So if you think about the awarding gap and everything that's linked to that, even dropout rates. So dropout rates, Black students are 1.5 times more likely to drop out than their white or Asian counterparts. Graduate outcomes are worse for Black students. So actually there is racial disparity there. So it begs the question, can racial trauma be one of the contributing factors to those discrepancies? And this leads me on to the PhD that I'm doing. So bringing all of this into the UK context. So we're using a scoping review to figure out what currently exists in the UK, in the US, and actually how does it all come together? And this all forms, or informs rather, the PhD. We're wrapping up phase 1 currently, and what we've done is a correlational study. So we've sent out questionnaires to London Met students. London Met students only, because what we've done is we've measured racial trauma, well-being, student engagement and self-efficacy, and then linked it to student data. So grades, attendance, a number of mitigation claims, that sort of thing. Because of this, though, the data we've received is not anonymous. And of course, that puts students off. So the amount of students we've received is really low, 50 students in total. this raises the question about how do we access hard to access participants, right? We haven't done the analysis yet. What we do know, though, is 78% of the 50 participants have reached the threshold for racial trauma in that group. So there's a lot to do here. Based on the challenges faced in phase 1, we're now working, or we've put in ethics for phase 2. And this removes that need for personalized details. So completely anonymous now, and instead they self-report on their journey. So their grades, attendance, student journey. So actually that removes that element of that. So hopefully there are more participants. This goes out to anyone willing to participate within the UK. This is for home students only, to make sure that there is homogeneity in the lived experience, because international students have a different lived experience of race than home students. Once these are done, we then move on to phase 3, which is the IPA, so qualitative study, looking at the retrospective experiences of racial trauma amongst students and staff. The reason we're doing this is to look at those nuances that the scales don't pick up. This all then feeds in to phase 4, which is the final phase here, a preliminary RCT evaluating the effectiveness of a positive psychology coaching intervention aimed at supporting students that have that high level of racial trauma. And you might think here, why positive psychology coaching? And essentially because it's aimed at facilitating goal achievement, well-being, and change. The focus remains on that positive rather than remedying any sort of deficit. So the emphasis is not on deficit correction, but rather the individual strengths. And the onus is not on the student to remedy that racial trauma, rather just focusing on the well-being, goal achievement, and the use of personal strengths. So essentially the PhD is exploring that under-examined link between racial trauma and the student journey, with hopes of figuring out ways to support students along the way and reduce that awarding gap. Thank you. Questions, comments, suggestions? Yes.
Just the study looked at historical racial trauma, how racial trauma is experienced in a person's life.
Within a lifetime. Really interesting though, because there's this idea of transgenerational trauma that's big in research at the moment. We don't look at that explicitly, but that is something to definitely think about moving forward. Absolutely. Thank you. Yes.
I'm just wondering whether participants have experienced sort of trauma from school and then it's manifested itself when they've gone to university, which makes the trauma worse. And my second part is how can we sort of bridge the gap between the trauma they've probably experienced at school level, but it then transcends into university, so it doesn't manifest itself when they then go into the workplace?
That's a really good question. So the idea is that it's cumulative, and we won't know that with just the numbers, and I think that's where the qualitative study comes in, to figure out what that nuance is. And the idea is that the intervention will support creating more of a positive kind of approach to that and well-being. So hopefully that has a positive impact on students then going into the workplace after that. Thank you. Okay. Thank you.
Hello. So our next speakers, I'm trying to set up, I think is Justin first, and then Precious. Yes. Just for the sake of time. It's a bit clunky this. I think I have yours. Yeah. Okay.
Good morning, everybody. I'm Justin. I work as part of the health team, and I'm here today to talk to you about a piece of work that I've been doing with Versus Arthritis, which used to be Arthritis Research UK. It's a large charity that supports people with musculoskeletal conditions. I've been working with them and a wider team for about 3 years now, and we were commissioned to do an evaluation of their physical activity programme. But I'm going to talk to you about one element of that programme today and part of the work that we did with them, particularly around the COVID-19 pandemic. So as we are all aware, during that pandemic, we had stay-at-home orders, we had movement restriction orders, we weren't allowed to hang out, and that impacted people in a number of different ways. Versus Arthritis at the time created a intervention called Let's Move with Leon. And this is the paper that I'm going to be talking to you about today. So I'll talk to you about the development of Let's Move with Leon, how it was created, but the evaluation itself looked at the reach of that particular intervention, which was launched during COVID-19 with the aim of getting people with musculoskeletal conditions to be more active, the representativeness of that intervention, so who is likely to use an intervention online in this unique situation. Is it representative of people within the UK who have a musculoskeletal condition? And actually, did it work? Did it improve people's physical activity or not? Did it maintain their activity? And other elements of that particular behaviour. So we used a model, a behavioural model called the COMBI model, which stands for capability, opportunity and motivation. And those three things need to align for a behaviour to occur. So actually, did this intervention work in terms of improving physical activity or maintaining it? And did it have any influence on people's capability to be active, their perceived opportunities to be active, and their motivation to be active? So how was Let's Move with Leon created? So we actually worked with Versus Arthritis to run a series of workshops to develop this digital intervention before COVID. Nobody knew it was coming at the time. And we encouraged them to go out and do some primary research as well as do a rapid review of the literature. So we did the rapid review of the literature for them to say, these are the reasons, these are the barriers, these are the facilitators to physical activity in people in the UK who have a musculoskeletal condition. And just to define what that is, that could be anything from arthritis to osteoarthritis, rheumatoid arthritis, back pain, any chronic long-term pain, muscular pain, all the different types of arthritis. We encourage them to go and talk to people, firstly, with these conditions to find out what was important to them about being active and why is being active important for people with musculoskeletal conditions. Well, there's quite a lot of research out there now that says actually being active can improve the condition itself, reduce fatigue, help reduce pain, which is one of the number one reported barrier, a number one reported issue with a musculoskeletal condition, help reduce pain, and actually improve well-being, as well as all of the other benefits of being active. So the Chief Medical Officer says that there's, I think it's 21 or 22 long-term conditions that can be improved by being more active. So we all know it's quite important. In addition to talking to 100 people with a musculoskeletal condition, they also have access to an online community, and they reviewed the online community for mentions of physical activity. So again, they could pull out all of the key things or try to pull out some of these barriers and facilitators to being active. They supplemented that with a survey of 815 people with a musculoskeletal condition. As I said, this ad hoc literature review which we did for them, and then we ran a series of workshops with members of their team and wider stakeholders to say, let's use a an intervention development framework to design an intervention for you to improve physical activity in people with a musculoskeletal condition in an online setting. And like I say, at this point, we didn't know COVID was going to happen. So we worked with a digital team, and at the end of these workshops, we created a intervention strategy, which they then went away and worked up. We also had a steering group created, made up of people outside of their institution or their charity, made up of other academics, people in the NHS, Sport England, who came to check and challenge this work, as well as patient representatives. Then COVID happened, so they accelerated the development and created this, Let's Move with Leon. It is a 13-week programme. I wonder if you can see it might be a bit small. So there's 13 sessions that people can complete. They do it in a sequential order, so they start at number 1 and work their way right the way through. There's an online community where people can go and share their experiences, and there's an activity booklet as well. So in amongst this, for anyone interested in health psychology, we coded all this up. So we've got all the behaviour change techniques that are included within this intervention, all the intervention functions that were being used, and all of the intervention implementation strategies that we used. So during the evaluation, we could pick out some of the key things that we thought were working. And we've got other papers that have been published on this. If people are interested, then I'm happy to share those afterwards. But we were in a unique situation. This was launched in the September. So I think it was March, wasn't it, that we started having lockdown. In the September, this was launched. So we had this period of time where there was this digital intervention that was available for people with musculoskeletal conditions. And we had an opportunity to evaluate it to see, in this unique situation, do digital interventions work when we have these situations where we've got lockdown measures. So the method we used to evaluate this, well, actually they had 26,041 users who'd signed up to this intervention when it was launched in September, and we had that data that we could take away and use as part of this evaluation. For anyone who's worked in intervention evaluation and research in this area, lots of charities particularly try and use before and after data, and invariably the data they collect isn't very good, because actually they don't really get the after. They're great at getting the before, but when they try and follow up with people, the numbers are very, very small. And that's what we found. So when we said, well, can you provide us with the follow-up data, actually it was about 400 people from this 26,000. So what we decided to do was do a cross-sectional survey. So we sent out a survey to these 26,000 people, asking a number of questions. Firstly, how active are you, using a recognised measure? How capable do you feel to be active? What opportunities are available to you, and how motivated are you? So we used this behavioural model to see if there was we could see if there was changes based on programme stage. We also said, well, which week are you in? So when we look at go back one, it's this 13-week programme, and people were communicated every week. So here's your next instalment of Let's Move with Leon, if you like. So they could tell us which week they were in. So from this cross-sectional survey, we could actually say, well, depending on stage of programme, how active are you, and and how capable do you feel to be active? Do you feel that you've got the opportunity, and are you motivated? So we could then do some comparison between stages. We used that cross-sectional data to along with the service evaluation data, and we tried to match the two up, because the service evaluation data they provided us with had gender, age, ethnicity, type of arthritis, length of time they've had the condition. So we could take some of that data and match the two up. So we then had an adjusted model where we could find those matches, which was, we hoped, a better predictor of some of the outcomes, because we were controlling for these other variables that could have actually influenced physical activity. So what did we find? Well, this adjusted model, which took account for a number of things. So as I say, self-efficacy, age, gender, ethnicity. There were some other questions that they collected: ability to achieve goals, time since diagnosis, and we matched it. So we've got on your left the unadjusted, which was the 2,751 cross-sectional survey, and on the right the adjusted. So we controlled for all of these other factors, and we managed to get comparison or links for 495. And what you'll see from here is actually, if we take the adjusted model, this program by stage, as people went through stages, they did improve their activity levels. So every stage they went through, it seems, according to this data, that they improved their physical activity levels. Obviously, we can't be absolutely sure. It's not a randomized control trial. We actually went on to do a control trial after this, which has also been published, which again suggested they improved physical activity. In terms of the opportunity, or their perceived physical opportunity, their perceived social opportunity, well, it said physically, yes, I feel like as I go through the stages, the opportunities are there for me, but it's a digital intervention. Social opportunity didn't improve, so they're not doing it with other people, not being encouraged by friends and family, which I guess we would expect for a digital intervention. In terms of motivation, it's broken down into two. So reflective motivation, I'm considering it, yes, I think it's important. Automatic motivation, those feelings, those emotions, doing things by habit. And both of those seem to improve as they went through the stages as well. And then being physically capable, but also mentally capable, psychological capability, having the knowledge, the mental stamina to continue to be active. Again, both of those seem to improve, which is good news. This graph shows these components, these behavioural components. So we've got in orange the physical opportunity, in red the social opportunity, in green the reflective motivation, in lighter yellow automatic motivation, and then the other two, dark blue and dark red, the physical and psychological capability. And you can see actually what we found is that it seems to increase with this intervention in the first sort of 3 to 4 weeks, and then levels off and then begins to tail off, which is what we see in a lot of kind of individual behaviour change type interventions. We see this rapid increase, things sort of stay the same for a little while and then they tail off over time. And in the long term, they never seem to really work and bring about long-term behaviour change. So who was most likely to use this intervention, this type of intervention during a COVID lockdown? It was mainly people who were older age, which obviously corresponds to people with musculoskeletal conditions, or sort of late middle age, 55 to 75, but they were mainly female, mainly white, with chronic joint pain being the number one condition, which had a moderate to severe impact on their daily life, but they had a good quality of life, and they had a good knowledge of what to do and why being active was important. So we're likely getting people that are motivated. It wasn't representative of the UK population of people with musculoskeletal conditions. Clearly, there's a number of ethnicities that aren't being picked up here. That could be about the digital intervention. Other research has suggested that this particular group are more likely to go and do digital interventions, but it might also be representative of the charity itself and the people that they engage with, or the people that engage with the charity. Possible outcomes, because obviously it was only a cross-sectional survey. This type of intervention seems to improve motivation, seems to improve capability to be active, and the opportunity, or perceived opportunity, but not the social opportunity. And it also seems that as people go through program stage, their physical activity increases, but then levels off and then begins to tail off as we go into the future. So long term, it might not work, but in a short period of lockdown, it could be a good solution. Here's the reference for this paper. As I say, we have done additional work, so we have gone on to do an RCT on this with just under 400 people involved, some getting the intervention, the others just getting usual care, which I'm happy to share those references with you. Just wanted to thank Sport England and Versatility themselves, because it was their funding that enabled this evaluation. Thank you for your time.
Thank you, Justin, for a really interesting presentation. I was interested in the level of motivation, reflective motivation. Were you able to differentiate pre and post lockdown? Did it span that period? Because you had a unique opportunity, which you identified. Sorry. If I can just quickly.
show it again. So the difficulty we had is because we did this in February, the survey went out. So some people would have been at 12 weeks and some people would have been at week 1. So it wasn't, you couldn't say what was the motivation in September and what was the motivation in February. All we could do is say what was the motivation of those in February and was the motivation of those in September who were there at that, who'd started it. So it was a point-specific data. So those that were earlier in the programme had lower motivation. Those that were later in the programme seemed to have higher motivation. But it was all taken at one particular point, so we couldn't say what it was in September and what it was in February.
I was just thinking about motivation waning.
Yeah.
Post-lockdown.
Yeah. What we've seen with the randomised control trial is that because we did 2 intakes, all of the figures drop as soon as you get to winter with everything. So it's particularly physical activity in people with musculoskeletal conditions, the time of year is really important because actually as soon as winter hits, pain gets worse, motivation decreases. So I think time of year is quite important. But in terms of the actual lockdown itself, it's difficult to say.
Yeah, that's interesting. Sorry, can I have a second? It's just about the demographic and about the level of access to digital interventions.
We recruited through their networks. So in the UK, there's about 18 million people with a musculoskeletal condition. We're taking figures from the charity. They claim to communicate with about 10 million of those. That level, we're not sure, but we went through Facebook advertising, through their people who've engaged with the charity and recruited in that way. They all seem to be able to access the programme. We didn't have any digital literacy issues. In our RCT, we had 1 person out of 400 who asked for their data to be removed because they couldn't work the programme and didn't understand how it worked. So it didn't seem to be an issue with that particular cohort, but that is people engaging with the charity rather than the cohort, the broad population of people with musculoskeletal condition.
Okay, thank you very much.
Thank you very much for that. I was interested in what you said about the, and I hope I got this right, that people who were more motivated, they've gone through more stages. Is that right?
So what we were looking at is to see if being part of the programme increased their motivation. So there was some. Where are we? Actually, some of these figures were higher at the start, so they didn't increase as much. So what we were finding, in terms of reflective motivation, you score out of 10. Even at the start of the programme, they're scoring at 7 and a bit. So they're quite motivated anyway. It does show that it did increase, but then tail off. We are getting people that are already motivated to make a change. Whether that was improved by lockdown, and actually I need to get out and do something, I'm not sure. But it did seem that people come into these types of programmes are already quite motivated and understand why it's important before they get there.
And I just wondered if there was a difference between the people who kept going through the stages and the ones who didn't in terms of that initial motivation.
Yeah, so because we did a cross-sectional survey and we weren't tracking people, there is an element of bias because those that we've got people that have gone through 12 weeks at that time, they've been quite motivated. But then we've also got people at various different stages. So we didn't. One thing is missing is an analysis of those that dropped out. The RCT suggested similar findings, to be honest, and we had less than 20% dropout in the RCT, and we imputed the findings, and we had similar sorts of findings to this. It does seem to increase things in the shorter term, but then tails off, and it doesn't seem to work in the longer term. Sorry, Telly. Oh, sorry. Telly.
Yeah, this is really a follow-up from Graham alluded to in terms of participation and representation of the Black and global majority members of communities in research in general and also in digital research and organizations, non-governmental organizations, voluntary organizations, whether they actually collect ethnic data to demonstrate diversity of their participation. I tried to did a research proposal to focus on that. What was your sense in terms of whether A, they collect data, and B, the level of participation, or whether there are any strategies to particularly address this issue?
So we obviously fed back that you are excluding a huge proportion of people here. The ad hoc literature review that we did, we actually then redid it and did it as a structured review of reviews, which again we've had published. And one of the outcomes of that was to produce a check sheet for the charity to say, here are all the barriers to activity, here are all the facilitators to activity. Any activity that you do, check off against these barriers and these facilitators. But in addition to that, at the bottom of the check sheet, we put all of the known issues in terms of physical activity, such as around people of a particular age are more likely to be active, men are more likely to be active, particular ethnicities are more likely to be inactive, people with lower education are more likely to be inactive, and said, please, with anything that you do, check against, ask the question of your programme, is it making health inequalities worse? And if it is, with this one, it's there's a higher intake of females, which is obviously, in that particular area, is hopefully reducing health inequalities, but it's all white females. So we encourage them to at least ask the question. They do collect data. Whether it's bringing about change, I'm not sure. I think it might be largely due to the people interacting with the charity, which is a wider concern.
So it's a very big question in terms of answer.
Yeah. Okay.
Thanks, Justin. That's really nice. I just wondered how you can sustain motivation, because you're talking about a 12-week period, but you really want people to carry this on really for the rest of their lives.
Yeah.
How have you any insights about how that could be possible?
I think this part of this, so a very brief answer. We've just done the second piece of work, which tries to look at a socio-ecological model of physical activity and all of the other influences on physical activity, kind of as a public health concern. And everything is around 12 weeks. We're going to do an intervention for 12 weeks. We're going to fund it for 12 weeks. And we've got this kind of short term, we're doing this problem, and then we're going to pass you on to something else which you can't afford or you're not interested in. So it's what's come out of that is actually having significant others who encourage activity. So engaging partners who are the ones that actually make these things happen. We haven't gone for a walk today. Let's go out. So, having in terms of community settings, having a social element to the program as well. So people are going not to be active; they're going to have a coffee, and that seems to increase motivation when you take it away from being active and you just incorporate it into things that they like to do. So embedding in their values, their attitudes, their beliefs. If you harness it around those things, it seems to have a longer term impact. But it's not around being motivated to be active; it's around being motivated to do things they enjoy.
Thank you very much. Thank you.
Let me set your slides right. It's a bit clunky, the system, but let me see your slides. If you help me, it should be the pressures. And so you take it from there. Yeah, that's fine. Thank you. Thank you very much. Just looking through.
Yeah, that's fine. Okay. Hi everyone. My name is Precious, and I'm a senior lecturer in health and social care. So I will be presenting on spirituality and people with intellectual and developmental disabilities. Obviously, 15 minutes. So I'm going to give an overview to contextualize the study. So obviously, this work is focusing mostly on my thesis as part of my doctoral thesis a few years ago. So just giving an overview of what quality of life is, religion, spirituality in the context of health and disability, and specifically focusing on people with intellectual and developmental disability. So quality of life, I mean, it's a complex construct which has multidimensional aspects to it. So depending on the definition you encounter, it might be slightly different, okay? But regardless of the definition you encounter, they tend to have common concepts such as general feelings of well-being, positive social involvement, or even personal potential. Okay, but the World Health Organization defines it as a personal evaluation of one's personal position in their lives in the context in which they live, specifically the cultural or the value systems in which people live in, and also in relation to their goals, their expectations, their concerns. The World Health Organization's quality of life measure includes spirituality, religion, and personal beliefs as part of its 6 domains, which argues that there needs to be a consideration of the spiritual aspect of an individual in the measurement of quality of life. Now, most researchers, including myself, would agree that the concepts of religion and spirituality are distinct, okay? So they're different. So this is a multidimensional framework that I worked with within my thesis. And where I come from is the fact that you may have people who ascribe or say, oh, I'm spiritual, but I'm not religious, okay? Or people who say, I'm religious and I'm spiritual. But basically, spirituality is seen as a fundamental aspect of human experience, okay, human development, irrespective of culture, of religion, okay? So it's often seen as the belief in the supernatural, belief in something higher than someone, a sacred, but also an area of life in which people are looking for meaning, okay, to connect with self, to connect with people, with the universe, with something other than themselves, okay? But religion, on the other hand, is institutionalized, organized patterns of belief, morals, and social structures that people create to fulfill their spiritual quest. Okay, so religion can provide an avenue for people to fulfill their spiritual quest. But spirituality doesn't always have to be fulfilled within religious context. There are people who do not practice religious rituals in order to fulfill their spirituality. But this kind of emphasizes the importance of considering the spiritual aspect of individuals. So the biopsychosocial spiritual model details this in the sense that for effective person-centered care, the spiritual aspect of an individual should be considered alongside their biological, their psychological, and their social life, right? But this is quite limited in terms of research when you think about clients, especially those with intellectual and developmental disabilities. And again, research in physical and mental health have found, not in population of people with intellectual disabilities, but in population of people with cancer, with chronic pain, even during COVID, that spirituality plays an important role in people's lives, in the way they cope, in the way they make meaning of conditions that they encounter. And a recent scoping review actually found that patients who were admitted in healthcare hospitals in the UK, for example, valued the spiritual care that nurses provided or were able to provide them with. However, some of the limitations related in the context of limited understanding. So some nurses didn't have an understanding of what spiritual care meant, how to provide it. And they also had gap in terms of education. There wasn't much education of nurses or midwifery in terms of how do you actually provide spiritual care. And I also found this in one of my research, that this was also the case in terms of support workers who work in residential care settings. However, even though this aspect of life is important, there continues to be limited attention in research, in practice, and also in policy. So a systematic policy review I did in 2014 identified a gap in the UK, in the national guidance on how do we actually provide spiritual support for this population. And even though they do encourage that people can participate in community activities and faith activities, there isn't really a national guidance on that. And also, if you look at the United Nations Convention on the Rights of the Child, they pay deep attention on how we should enable children and young people to, have experiences in the religious context, the freedom to do that. But not much attention is dedicated to that in the United Nations Convention on the Rights of Persons with Disability. Now, the few research that exists in disability studies, some of them mostly conceptual papers and a few empirical studies, have found that people of this population do have an understanding of spirituality and what it means in relation to their life experiences. They've also found that people who ascribe to either a religious faith or who have found meaning in life tend to use it as a framework for making sense of when things happen to them, okay? And also, it helps them to provide like a sense of acceptance, a sense of security, and a sense of comfort in situations that they deal with. And it also provides them with a pathway to expand in their social network. This group of people with intellectual and developmental disabilities, are known to have fewer social networks. So spirituality in the context of, for example, religious practices or religious communities tend to help them to expand their social network in that aspect. So my research mostly focused and specifically looked at the quality of life of people with intellectual disability, but how spirituality influenced their perception of their quality of life. Now, most research tend to derive from the US, from Germany, and Austria. And this is actually the only study, I can actually say, that has specifically and directly looked at the link and the relationship between how people who are diagnosed with intellectual disability perceive their quality of life. So I used a mixed method approach, where I used quantitative measures such as Sherlock's Quality of Life questionnaire, which had 4 components or 4 scales. It had the satisfaction scale, competence scale, empowerment scale, and social belonging scale. And I used the systems of belief inventory, which is a spirituality measure that you use in quality of life studies. Okay, and so within that, you would have a scale that looks at people's beliefs and religious practice and the support people gain from people that ascribe to such religious practice, for example. Again, the data were collected simultaneously, they were analyzed independently and then put together just to gain a bigger picture. As you can see, obviously one of the limitations is the fact that it's only 36 participants. Obviously that is limited in the context of quantitative data, but the qualitative data enabled a fuller picture of what was happening. So looking at the quantitative data, so the spiritual belief inventory, systems belief inventory scale, they find that people in the faith-based service, for example, scored higher in terms of their spirituality, okay? They were indicating to have a belief, to practice those beliefs. Those who were in the non-faith-based service, there were few of them who were indicating to have a belief and practice those beliefs and gain support in the communities as well. And then you had the social, the quality of life questionnaire, which most participants indicated quite highly in terms of their perception of their quality of life. Almost all of the areas were significant. Only one of the areas in the scale, the empowerment one, was not significant. And again, these data were put together and the correlation, so the strengths of the relationship between these two measures showed that there is a relationship between people's spirituality using the systems of belief scale and their perception of their quality of life. Now, this is just an indication. There are more. I mean, if you're interested, my study kind of outlines more quotes from participants, kind of showing some of the qualitative data in terms of the themes that came up from this. And one of the themes is the use of religious and spiritual rituals. And within that theme, there were 2 sub-themes, which were a sense of community and a sense of peace. So as you would see in some of these quotes, you can see how participants were perceiving their aspects of their life from the spiritual lens in terms of what it contributed in relation to their well-being, for example, in relation to their psychological state, in relation to community and social, socially participating and benefiting from communing with people who had the same belief, for example. Again, what this leads us to, what this shows is that spirituality does have an impact on how people with intellectual disability perceive their quality of life. And even though it is a small sample and so it poses challenge in terms of generalization, this was actually, some of the findings were confirmed in a recent study, an Austrian-based study that looked at the quality of life of people with intellectual disability and those who are deaf in Austria. And again, it could be argued that denying people with intellectual disability or developmental disability who do want to participate or have spiritual or religious experiences the opportunity to do so is actually going and limiting their legal rights in the context of them experiencing all aspects of human experience and the potential to fulfill all aspects of their personal potential. And so some of the implications and some of the recommendation is that residential care homes specifically could focus on prioritizing time to provide spiritual care for individuals alongside their biological, psychological, and social needs as well. And in doing so, maybe they could collaborate more strategically with religious organizations if there are limitations in terms of knowledge or limitation in terms of not having enough time to train some people to do that. And again, there needs to be more training and more education of healthcare professionals in how to provide spiritual care. You may see some people that say, yes, I have a belief, and they assume that they have the skills to provide spiritual care, but they don't. Even though Ross et al., they have come up with this EPIC project, which is creating a framework for training nurses and midwifery students on how to provide spiritual care competence. But this is kind of lacking in the context of, for example, support or healthcare assistants or other professionals. And so more research is needed to kind of establish more training, but not just that, but also efficient spiritual assessment of people with intellectual disabilities, but also improve the provision of spiritual care for this population. That is all, I believe. Yeah, thank you. Hi.
Thank you very much. Very interesting presentation. May I ask something very simple? How would you define or give an example of spiritual care?
Spiritual care, yeah. I mean, it's all rooted in compassion as well, right? But also it's all rooted in trust, but also in having an open-mindedness. Because you may have a mindset that, yes, I know what spirituality means, but maybe in the context of religion, but then you may not be open to someone's spirituality that is not contextualized within religion. So I think spiritual care is often different depending on the individual that you encounter, right? And so there needs to be a bit more training on how do you approach the topic, for example? How do you gain consent or even find out if people have a spiritual need or a spiritual desire in the first place? And what I found, because I said this is part of the larger study as part of my dissertation, is that the support staff, because I also looked at the staff in addition to people with intellectual disability, the ones in the faith-based service had training on how to provide spiritual care. So, for example, they had staff who were both Christians, but who were, for example, from other religious groups, but they had training on how to provide general spiritual care, irrespective of the religion that the clients had. But again, bear in mind that the service that I looked at was a Christian faith-based service. And so even though not all of them practice spirituality, they also were able to provide effective spiritual support in that sense because they had that training. So the training takes them through, opening your mindset in terms of what spirituality is. So they go through definitions of what spirituality is or what it looks like and how it's not one size fits all, if that makes sense. Hope that answers the question.
Mm-hmm. Interesting study. Just 2 points. Your approach reminds me of the importance of engaging with the decolonization methodology. Within decolonization methodology, the issues of spirituality will be part of the frame in terms of the indigenous communities, local staff. The other point is in terms of the training and development of those who work in health and social care in terms of spirituality. I'd like to suggest that the existential approach will definitely have training you to engage with the spiritual context, because in terms of the existential framework, one of the key areas is being in the world and your being in the world in terms of the spiritual. That isn't about religion as such, but nevertheless, depending on who you work with, you can engage in that. So it becomes part of trained skills and practice in general. That's for me the area that we need to be developed.
Yeah, so I guess it would be quite interesting to explore what practices are taking place currently, to use that to inform, you know, if you're using the existential approach.
Yeah.
Just make a comment, really. Quite old, so I've been to many research meetings. This is the first time I've listened to a talk about spirituality, and I've often thought that that's something that's missing from health and well-being. So I think it's very appropriate for this forum. So thank you very much for that.
That was very interesting. Thank you. I'm Italian, so I have a great connection with religion and spirituality. I totally agree with you, because I worked in a hospital in a home care, and I think that there is very, very little spirituality offered to patients and clients. Then again, at the beginning you said something as there is distinction between spirituality and religion, which my point of view is yes, but maybe not. But I'll explain, because when then after you said that there was more, people are more prone to be spiritual if they had a religious background. You know, if they believe in that faith. You know, if you go someone who has no religion at all, they probably are less, I suppose, but I'm assuming they are less spiritual. That, you know, they look inside, you know, just like connect with another being. But some people doesn't have that, I suppose, that they just like are less spiritual.
It doesn't make them less spiritual, it makes them less religious in a sense. So just looking at this multidimensional construct that I have is the fact that spirituality, right, because not everyone believes in God, for example, but people believe in human beings. People believe in the power of love. People believe in the meaning beyond themselves. Does that make sense? So in that sense, that is spiritual in a sense for them. Does that make sense? So does that help? Yeah. So yeah, but the spirituality you're talking about is within the religious context, which is religious spirituality. But then the other aspect is non-religious spirituality. Yeah. Okay.
Yeah. Just from your overall reading, does a belief system, spiritual belief system, does that improve outcomes, health outcomes?
Yeah, it has been found not even in just people with intellectual and developmental disability, but in general health, like people with cancer, chronic pain, for example, or depression, or people going through loss. Yeah, it has been found. And again, there are other factors. It may not just some of the factors could be the fact that they believe in a God, for example, but also is the social network that they have that also helps them in coping with those, you know, things that they encounter in life. Yeah. Thanks.
Thank you very much.
Thanks.
Thank you to all the speakers and the audience for your questions for the first part of this conference. We will return, we come together. You're all welcome to come back at 2 p.m. Please, and help yourself to whatever is left of coffee there and biscuits, please. Thank you very much.